This is the human side of healthcare, where we explore all aspects of today's ever-changing healthcare environment. Brought to you by the Dallas-Fort Worth Hospital Council and featuring CEO Stephen Love with co-host Thomas Miller. Now, let's make healthcare human again.
Welcome to the human side of healthcare. We're delighted you're with us today, and we want to talk about a topic referred to as sepsis. You know, Thomas, even before we begin our interview, did you know that September is Sepsis Awareness Month?
Yes, and it's actually a great month to shine the light on a disease that so many people, it slips up on them and even can find you at home. And then you try to go to the hospital, but it has such a short time window before it just explodes that you can die before you get treatment. That's why we're going to shine a light on it today.
Exactly, Thomas. And that's why we're delighted that we've got with us today Reid, who's the clinical program coordinator at Parkland Health. Ryan, welcome to the show.
Thank you so much for having me.
You know, to really set the landscape, so to speak, for our listeners, can you define what is sepsis?
Yeah, so sepsis is the body's immune system having an extreme response to an infection. This is usually caused by a response to a bacteria, a virus, or it could even be fungal. What happens in sepsis is that the infection gets bad enough that it triggers a kind of chain reaction in your immune system so that your body's response is so strong that it ends up harming itself. So with this, some of the early signs you want to be watching for can really be fever, elevated heart rate, maybe rapid breathing. And then later on, you might have a drop in blood pressure or even mental status changes like confusion, disorientation, or you might notice just someone's being less responsive. And that's really an important thing to note here, especially when you have older patients coming in and you have family members saying, hey, they're just not acting right. I think they're having a stroke. It could actually be sepsis.
You know, that's a good point. And I'm assuming with elderly people, maybe dementia, sometimes it's hard to diagnose as well.
Yes, that's exactly correct. Sometimes, it could be dementia, but sometimes when you do have an older patient that is acting confused, that can be a sign of a worsening infection.
You know, the other thing, I'm not sure people realize how serious sepsis is. I was reading that 270,000 people in the United States die annually from sepsis. Can you expand on that? Because I think less than 1 year old and over 65 is where most of these people were.
Yes, no, that's correct. So the one thing to note with sepsis is that it is a leading cause of hospital mortality. There's this estimate by the CDC that about 1 in 3 patients who die in the hospital have sepsis, and that can be a really big number. One thing to point out here is that I often think gets misunderstood. The majority of sepsis patients who are actually identified in our emergency department, so at Parkland, that's really around 85% to upwards of 90% of our patients who are septic, they walk through the doors already septic, or if they do become septic later on in their stay, it's overwhelmingly because of an infection that they already walked in with.
You know, I don't want to scare our listeners, but you just brought up an excellent point. People come to the emergency room, they have the symptoms, they're diagnosed, and yet 1 in 3 people in the hospital that die from sepsis. So they have it and then come to the hospital and need immediate treatment.
Yes, that is correct. Sepsis can be really deadly, and the treatment is time sensitive. So it is really key that we identify quickly and we treat it early. So just to point out, if you are indeed septic, your risk of mortality increases by about 4 to 8% for every hour you delay getting antibiotics. So, for example, at Parkland, the way we've addressed that is we have a whole process set up for our septic patients. If you were to come into our ED and we identified you as being septic, we would have a system in place to expedite your workup, get interventions on board like antibiotics, fluids, and other medications on board just fast, really as fast as we can, ideally within an hour, since that is what's indicated through research as really maximizing your chances of a good outcome.
You said 4 to 8% per hour. would be the increase in the potential for death rate. That means when you exhibit these symptoms, you've got to quickly get treatment with antibiotics. I mean, you can't wait 2 or 3 days.
Yes, that is absolutely correct. So just to point out, if you or a loved one think that you have sepsis, exactly what you said, the important thing to do is to act fast and get assessed by a medical professional as soon as possible. Preferably, this would be in person. Either go to an urgent care or go to an emergency department. If you are in a situation in which you find you can only do telehealth, for example, get someone to assess you ASAP. Don't wait a day for this to be assessed. And of course, if you are experiencing a medical emergency, we recommend call 911.
You indicated you can go to the emergency room, or if you immediately get seen by a physician, even if urgent care. Is there a laboratory test or something that can confirm you have sepsis?
No, there is not. And that is something many in the medical community are trying to figure out, since that would really be transformative to care. At Parkland, we've integrated AI algorithms into our charting system to help catch patients who might be septic or be becoming septic earlier on. And that system will send us an alert about those patients. So that does provide a great help, and we have a whole team continuing to enhance that. As far as labs are concerned, just things to expect. We have lab tests that can identify what the infection is. We can do a bacterial blood culture, for example, and that would help us as far as informing us with if we need to give you a specific antibiotic. We can also do tests to see how your immune system is responding to the infection, like checking your white blood cell count, and different labs to assess for organ function and oxygenation, like a lactate level. But there isn't one lab that can tell us, hey, this patient is septic.
You indicated earlier, I think you said fungal, bacterial, or viral infections potentially could trigger sepsis. Is that correct?
Yes, that is correct.
Could you develop sepsis without a prior infection? I mean, could you contract some form of sepsis without a previous infection?
No, so that's one thing to point out, is that sepsis only occurs once your body has that dysregulated response to an infection, but you first need an infectious source in order to start your immune system in a way kind of going out of balance.
That's a good point. So that's why if you have an infection, like let's say you have an infection in your lung, like pneumonia, or if you had an infection of the skin, let's say you have a skin infection, potentially it could become septic. Is that correct?
So that is correct. Potentially that infection could become septic. So one thing to stress with your listeners is that that is not always the case. In fact, most times that is not the case, especially when you get that infection looked at early and checked. And if your provider determines that you need to have interventions like an antibiotic with a bacterial infection, or let's say an antiviral with some kind of viral infection, if you get that treated early, that is really the best way to prevent an onset of sepsis.
And September is Sepsis Awareness Month. This has been Ryan Reid from Parkland Health. When we come back, we're going to switch gears and talk with Jessica Aguilar, welcome her back to the show from JPS Health, plus tell you about an old rock and roll star you probably know who caught sepsis at home and died a few days later in the hospital. Stay with us.
This is the human side of healthcare, where we feature healthcare's hottest topics and what our North Texas area hospitals are doing to make healthcare human again.
Welcome back as we continue our discussion related to Sepsis Awareness Month, which is September. We're now going to have another guest, and she's coming back. We've had her previously, Jessica Aguilar, who's the clinical sepsis RN at JPS Health Network. Jessica, welcome back to the show.
Thank you so much for having me.
Let me start with this. What is septic shock?
Septic shock is when the body goes into basically a fight or flight. This infection has caused the body to react in such a way that your organs start to shut down. So septic shock is kind of almost what they call a cryptic shock. And it's to where the infection has gone so far that a lot of times you're in the ICU, the intensive care unit, or you can be on vasopressors, which help to maintain your blood pressure. A lot of times you're intubated because you can't breathe for yourself because that infection now has caused organ dysfunction and even organ damage to your lungs. It's a very, very serious illness.
You know, Thomas and I were talking, and Thomas, why don't you expand about what you told me about the musical band Three Dog Night? I'm old enough to remember Three Dog Night.
I know, you and I both. Jeremiah was a bullfrog, right?
Right.
Now, that wasn't Corey Wells, but Corey Wells was one of the 3 band members of Three Dog Night. And at, I think, 70 or 71, he wasn't that old. He had a very treatable form of cancer, and they were treating it. But then all of a sudden, he developed a really stabbing back pain and started to really crash at home. They had to call 911. They took him to the hospital on a Monday night. He died the next day from septic shock.
Wow. That is a story that we hear it a lot, right? You go home, you're fine, you're fighting something else. Say if you came into the hospital and you had a stroke or a heart attack, or even maybe you're in a motor vehicle collision, and now you get to go home after it, and then you get home and you come back because your body has been exposed to an infection and your body ramps up, and before you know it, if you don't get treatment within that period of time, it can progress to what I was talking about earlier, which was septic shock, and it can be fatal.
Let's talk about kids now. I've done a little research, and many times children age 1 and younger can develop sepsis. Why is that, Jessica?
So kids that are 1 and younger, they don't have that full immune system yet. It hasn't developed. And so when they're born, their immunities come from that mom, which is why we encourage breastfeeding, because you get all those maternal antibodies. You get the antibodies when you're breastfeeding, and so that's why we encourage it. With that, those babies, until they reach about 18 months or really 24 months, they really have a stronger immune system than they did. So 1 and under, that's why we tell you to, make sure you're monitoring their temperature. Don't let people that are sick around them because they have such a weakened immune system that they aren't able to fight off those infections.
You know, Jessica, could this be something as minor as a skin irritation? Maybe it festers, but it leads to sepsis?
That's a great question, and especially because we live in Texas, right? And it's mosquito season all the time. But for a mosquito bite, think about it. If you have even just a bump, but if you had a mosquito bite or a bug bite and you scratch it, right, you're taking that protective layer of skin off. And so then that exposes you to get infection in. And if you don't get it cleaned properly and really make sure that it, stays dry and that it's not letting anything from the outside in, you don't want to get germs in that. And that's exactly what happens in what you're describing. Is you have a skin rash or a bite, you scratch it, and you take that layer off. Now bacteria can get into where that bite was. And then you may notice that your arm is starting to get red. It may start to feel like it's harder on the surface. You may start to have a high temperature. You may have a high heart rate. You can have, obviously, you're not going to have a white blood cell count, in the community before you come to the hospital. But we want to make sure that we're looking at your respirations. Are they more than what your average is, which is about 16 to 20? And then what happens is that your body is now reacting to that infection that it has gotten. All that came from literally a bug bite that we scratched.
Would another symptom be, for example, if you had a bug bite that you scratched and then you noticed red streaks going up your arm, should you seek attention pretty quickly?
Absolutely, because that streaking is letting us know that that inflammation and that infection is starting to push out. And the further it gets out, the further that infection spreads. So we want you to come in right away. We want you to see a provider. It doesn't matter where you go, what hospital, what ER, what urgent care, but be seen. Don't delay it because you don't want to end up down the road with having it get what they call necrotic, where the skin starts to die, and then you basically have amputation or something else further.
Let's assume that someone is exhibiting the symptoms of sepsis and they present themselves at the emergency room. What is generally the treatment protocol that would be followed?
So that's a great question as well. We have what we call a sepsis bundle. So you come in, we think that you have sepsis. We want to treat it aggressively. So we'll give you things like a normal saline IV bolus. So we'll start an IV on you, which is a little catheter that goes in your hand or your arm, and it lets us get fluid to you really fast. We're going to get some blood cultures just because we want to make sure if that infection is in your bloodstream or not. So we'll get blood cultures, and then we'll give you what they call broad-spectrum antibiotics. So these are medications that are used to treat multiple kinds of infections, because a lot of times we don't know what you'll present, what the actual sources that you present with, and so we want to make sure that we're getting it treated right away. And then you will get, of course, if you needed to, antibiotics and admission to the hospital, depending on how severe it is. If you were in septic shock, of course, we would talk about doing vasopressors and ICU level of care.
I assume that there are different degrees of when you can intervene. So some people may come to the emergency room and they came just as soon as they noticed the symptoms. Could they potentially be treated and then go back home? And then others, as you mentioned, if they're having septic shock, could end up in intensive care?
Absolutely. So it all depends too. If you think about it, like if they have congestive heart failure, they have diabetes, if they have multiple things that are affecting their health anyways, they're not as able to have that great immune response that somebody without all the comorbidities would.
If you develop sepsis and you are treated and you have a full recovery, is there a chance that it could reoccur more frequently if you develop another infection?
It always has the chance to reoccur. And again, the time you spend in a hospital for sepsis, even if you get to go home and you don't spend time in the hospital, your immune system gets weakened just by being in the hospital. And so it is likely that it could happen, but it's not something that I would say happens all the time.
Jessica, this is Thomas. Any prevention tips for sepsis?
Absolutely. Thank you so much for asking. So you can prevent sepsis by, number one, first and foremost, really understanding and being aware of and in tune to your body. Know that your body it's kind of like a car, right? You have to put into it what you want to get out of it. So make sure that you're having regular visits with your provider. You want preventative care. That's where they find things before it gets to the point of having to go to an emergency room. We want you to make sure that you are, if you're a diabetic, that you are monitoring your blood sugars, because we know that blood sugar elevations can delay healing time. Other thing is that first and foremost, wash your hands. Don't forget, when you wash your hands, you got to rub in between your fingers and your palms, go all the way up to your wrist. Wash your hands before they're visibly soiled, and use hand sanitizer, alcohol-based, generally in between. We also want you to maintain a healthy lifestyle, because mobility makes you stronger, makes your body stronger, makes your heart stronger. And oral care. This is a new push, good oral care. So honestly, most people brush their teeth maybe once or twice a day. A minimum of 3 times a day is what's recommended. And we are encouraging everyone, especially if you find yourself in the hospital, make sure you brush your teeth, wash your hands, keep your appointments, have appointments scheduled before you leave the hospital. So oral care is just very important.
Great. Thank you, Jessica. This has been Jessica Aguilar from JPS Health. Great to have you on again. Now, when we come back, we're going to talk about vascular health. This is your heart, but how it shows up all over your body. Next on the human side of healthcare.
Welcome back to the human side of healthcare, where we explore how to take better care of your health so you can live a happier, healthier life. With DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome to the human side of healthcare. Delighted you're with us today. We're going to talk about a subject today that involves vascular disease. And we're going to be talking with Dr. Michael Siah, who's a vascular surgeon and a limb salvage physician at Texas Health Presbyterian Hospital in Dallas. Dr. Siah, welcome to the show.
Thank you, Steve and Thomas, for the opportunity to talk about vascular disease. I'm really excited to be here today.
You know, to set the stage for our listeners, can you explain what vascular disease is and how many people in our population are affected by it?
When we talk about vascular disease, we're basically talking about an inflammatory process that affects the blood vessels that carry oxygen and nutrients throughout your body and remove waste from your tissues. So common vascular problems happen because plaques slow down or block blood flow inside your arteries or veins. This phenomenon, the $5 word that we use as physicians to describe it, is called atherosclerosis. And the primary risk factors for the development of atherosclerosis include smoking, diabetes, hyperlipidemia or having elevated levels of cholesterol, and having high blood pressure or hypertension. Additionally, as we get older, the frequency of vascular disease increases. And oftentimes this pathology affects all the artery beds in your body. So that includes your coronary arteries or the arteries in your heart, your cerebrovascular arteries, which include the arteries in your neck or your carotid arteries, as well as the arteries in your brain, as well as the arteries that supply blood flow to your intestines, your abdomen, and the arteries in your arms and your legs, which we call peripheral arterial disease. And independently, they all can cause different types of symptoms or problems.
You mentioned the carotid artery. Can you go into a little more specifics or even other ailments that are impacted through vascular disease?
Absolutely. So when we talk about carotid artery disease, basically refers to the development of plaques or blockages in your carotid arteries. Now, your carotid arteries are very important arteries that supply blood flow to your brain, and they're located in your neck. The development of plaques in this location has been shown to be associated with the risk of stroke. Now, not every blockage in your neck is going to cause a stroke, but in natural history studies looking at the carotid arteries, in certain patients, particularly patients who have blockages greater than 60%, they may have a risk of stroke that's 11% over the course of 5 years. So to decrease that risk of stroke, we put patients on a host of medical therapies such as cholesterol medications or statins, antiplatelet agents like aspirin or Plavix, and those have been shown to decrease your risk of stroke. But as a surgeon, in addition to those medical management options, we can do surgeries, which have been shown to decrease your risk of stroke by 50% over that same time interval.
What are some of the procedures you can do to help prevent stroke?
So it's important first to identify patients that would benefit from a certain type of operation. There are a host of surgeries that are available to us. And not every patient needs to have an intervention just because they have a blockage in the arteries of their neck. But in the patients who would benefit, and that's up to the discretion of a vascular surgeon, there are three primary ways in which carotid arteries are fixed. Now, the gold standard to which all therapies are compared is the carotid endarterectomy, which is an open surgical procedure where we remove the plaque from the body and repair the artery such that it won't develop a stenosis or recur. The disease process shouldn't recur over the course of a long period of time. Now, newer technologies, such as carotid artery stenting, where we are able to repair the carotid artery with a stent, are performed by poking the patient in their groin and advancing a series of protection devices and ultimately a stent to open up the artery. More recently, over the course of the last 5 to 10 years, a new therapy, which involves a small incision as well as the placement of a stent, called TCAR, or transcarotid artery revascularization, is something that has revolutionized the way in which patients with carotid artery disease have been treated or can be treated. Now, when we think about these options, the big things that I worry about and patients should worry about is, one, what is the risk of stroke from the procedure? If we're doing an operation to prevent stroke and it introduces a potential risk of stroke, we need to make sure that our interventionalist is very experienced. Additionally, because these patients have atherosclerosis of their cerebrovascular arteries, they likely will have some degree of disease in their coronary arteries. And we need to mitigate that risk of heart attack or adverse events associated with their cardiac disease in conjunction with determining what the benefit would be of treating their carotid arteries. Now, these three options are available, and I would say the majority of vascular surgeons can perform all three operations, are great tools for every physician to have available to their patients.
Thank you. That is excellent, and really appreciate you going through that detailed explanation so our listeners understand the importance of preventing strokes. I'm going to shift gears a little bit. In your introduction, I said that you are a limb salvage physician. We all know that we want to prevent any kind of amputation. We always want to preserve all appendages. But can you explain to our listeners the relationship between cardiovascular disease and sometimes the need to, unfortunately, have an amputation?
Absolutely. So cardiovascular disease refers to that underlying disease process that is systemic. It affects all the blood vessels in our body. So if you likely have coronary artery disease or plaques in your coronary arteries or the arteries in your heart, you likely will have plaques elsewhere in your body. Now, when we think about plaques that affect arteries that ultimately could potentially lead to amputation, we're talking about peripheral arterial disease. Now, it's important to note that the majority of patients who have peripheral arterial disease will never need to undergo surgery or will never go on to need an amputation. The supermajority of patients, greater than 90%, will never need those things. Now, around 30% of patients with peripheral arterial disease will have some spectrum of symptoms, and those symptoms are usually reproducible pain with exertion. So patients get up, they walk to the mailbox, they may feel crampy pain or fatigue in their legs. They stop walking, that pain resolves, and then when they walk again, that pain will occur. Those symptoms, or that constellation of symptoms, is called claudication. The majority of these patients will never need an intervention, and they'll never go on to need an amputation. Only 1 to 2% of patients like this will go on to amputation. So we're talking about a very, very, very small number of patients. But like you mentioned, when people talk about amputation, it's a very scary thing. So when you described me, or I'm a self-described limb salvage expert, I'm talking about taking care of that 1 to 2% of patients, where oftentimes they present with pain continuously in their feet or toes, or they present with a non-healing wound in their foot. Again, it's important to note that this is the very, very small number of patients. And if we can do something to get patients to heal or to ultimately prevent amputation, we can empower our patients to take control of their lives and get back to doing the things they love. Amputation, or thinking about amputation, is really important in patients with peripheral arterial disease because it oftentimes represents a failure of our healthcare system to deliver care to our patients in a timely fashion. And sometimes patients with limb-threatening ischemia will present to the hospital for the first time in many, many years. And I think that amputations occur primarily because of advanced disease at the time of diagnosis or presentation, sometimes due to a misdiagnosis or a wrong diagnosis. So while I work to improve blood flow, I require and I really lean on other healthcare providers to identify these patients, to identify those at-risk patients, those smokers, those diabetics, patients with high blood pressure, high cholesterol, or renal disease. So once we can identify these patients earlier, especially patients with claudication, before they develop wounds or rest pain, these patients should be getting screened, and abnormal findings should generate a referral to a vascular specialist so we can treat these patients sooner. The reason why amputation is so significant is there's a tremendous mortality associated with amputation in patients with peripheral arterial disease. Some studies even demonstrate that if you go on to get an amputation, there's a 25 to 50% mortality at 1 to 2 years. And this is likely due to their underlying comorbidities as well as the patient's loss of functional independence. And that, coupled with the psychological implications this can have, it can be absolutely devastating on a patient as well as their family unit.
You know, that is some statistic you gave in your answer. If you do, unfortunately, have to have an amputation, sometimes 25 to 50% will have the mortality rate within 2 years. That is amazing. Thank you for that detailed explanation. You know, you mentioned lifestyle choices, getting exercise. You know, we shouldn't smoke. You may have complicating chronic illnesses like diabetes. How does genetics come into play with cardiovascular?
Well, we know that there are some vascular conditions that are directly associated with genetics, but at present time, research remains ongoing. Now, routinely, genetic testing isn't performed for patients with peripheral or cardiovascular disease, but it would be really nice if we could identify and recognize patients who are particularly at high risk for the development of cardiovascular and peripheral arterial disease. We need to recognize and identify the pro-inflammatory and multisystemic nature of diabetes a little bit more effectively, because the link between diabetes and cardiovascular mortality has been well established.
We're talking with Dr. Michael Siah, vascular surgeon from Texas Health Dallas, how to take care of our whole vascular system. And one question, does this affect men or women more? Find out next on The Human Side of Healthcare.
Covering the healthcare topics that matter most to North Texas. This is The Human Side of Healthcare with DFW Hospital Council CEO Stephen Love, along with Thomas Miller.
Welcome back. Heart disease still is the number one killer in America, but it goes oh so much farther than just our heart. In this segment, we're continuing our conversation with Dr. Michael Siah from Texas Health Dallas about the health of our entire vascular system. Steve?
You know, you mentioned a lot of things today about the current treatment, especially some of the procedures to prevent stroke. But Dr. Siah, as you look into your crystal ball, what's on the horizon for treating cardiovascular disease?
Well, when I think about peripheral arterial disease in particular, we need to remember that the majority of patients with peripheral arterial disease will never need an intervention, and that intervention or treatments should be particularly reserved for patients with lifestyle limiting or disabling claudication symptoms or patients who have wounds or rest pain. Now, fundamentally, what we need to do in the future starts with what we have available to us today. We need to effectively start treating blood pressure. We need to effectively start controlling people's hyperlipidemia with cholesterol medications. We need to create new pathways to lead to more effective smoking cessation. And we need to implement supervised exercise walking programs, because all of these things are available now. They're reimbursable by CMS, and they have been shown time and time again to be effective in preventing amputation. When patients fail these things or they're unable to implement these programs, we have to aim for revascularization, whether it's doing minimally invasive techniques or good old-fashioned open surgery, so that we can prevent these amputations. But, you know, things that particularly are interesting to me are the new technologies that are available. Technologies like lithotripsy, where we've implemented technologies that have been used to break up kidney stones, to break up plaques in the peripheral arterial system. There are new balloon technologies that are more predictable and potentially more durable than previous balloon technologies that have been used over the last 15, 20 years. I also think some of the more exciting technologies and the advancements in the field are technologies that will allow physicians to remotely monitor how well blood is getting to different places in patients, and technologies that will allow us to quantify and predict healing in ways that at present time we simply just don't have. And then furthermore, these new technologies allow us to treat blood vessels in areas that historically haven't been able to be treated. And I think all those things coupled together will ultimately lead to better patient outcomes, less amputation, and more patient survival with a better quality of life.
That's a great answer. And I did want to ask you this. In your practice, I'm sure you see all patients, but with cardiovascular disease, and I know that's a wide range of diseases, from a gender point of view, does it affect men more than women, or is it more equal?
So what we know from historical studies is the frequency with which cardiovascular disease affects men occurs more commonly than it does in women. But that's also because previous studies haven't effectively or accurately captured real-world patients. We know that cardiovascular and peripheral arterial disease is associated with a higher mortality in women. And ongoing studies are trying to recruit patients that are more reflective of a typical patient's, or a typical physician rather, daily practice. Now, I would say that I see an equal number of men and women. And knowing what we know about the severity of the disease in women, I oftentimes find myself being a little bit more aggressive in women because I know the mortality associated with their disease process is slightly higher.
Thank you for that. And also from a patient profile, does it affect or impact minorities, or is it in any way related to race?
Now, absolutely. I think that diseases like hypertension, hyperlipidemia, and diabetes disproportionately affect ethnic minorities. And that's one of the challenging things as a surgeon, because these vulnerable patient populations are challenging to treat, not because of any ethnic component, but rather sometimes the determinants of health, like access to a physician, the ability to get a ride into the hospital, the ability to have a support network at home, is sometimes more challenging. And I think it highlights the underserved nature of these populations. So, I've worked at multiple county hospitals, since during training and here in Dallas, and you recognize different challenges that affect these patients outside of the operating room, which can make it a little bit more challenging to take care of these patients in the same way beyond the OR.
So, Dr. Siah, you mentioned kind of the big three: blood pressure, cholesterol, smoking, things that we're familiar with. And then you mentioned exercise and a Medicare reimbursed walking program. I'm curious, how much walking is involved in that program?
So in a supervised exercise walking program, this is like a prescription level walking program where patients walk 3 to 5 times a week at a certain duration of time, at a certain elevation or incline rather, where we objectively assess the development of symptoms and how far patients can walk pain-free. And if we monitor these patients over the course of 6 months, these programs have been shown to increase pain-free walking distance. Now, they're doing them purely based upon the patient and the patient's biology. There's no additional medication or anything else that we have to give these patients. And what walking does in this sort of environment is it allows a patient to be coached through to understand what's going on in their body. And as they walk, they recruit and develop new blood vessels to better supply the muscles in their lower extremity. Over time, that has been shown to be just as effective as an angioplasty. The problem is these things aren't super easy to come by. Availability isn't always ubiquitous. And I'm not entirely sure that most healthcare systems recognize the potential benefit to patients implementing this non-invasive but therapeutic modality of treatment.
You've just described the social drivers of health and how it does impact people, especially with chronic disease. We've got a great group of listeners out there. I'm going to give you the last word. What message would you like to leave with our listeners related to cardiovascular disease?
Ultimately, our population is aging, and the diseases that contribute to the development of cardiovascular diseases are on the rise. Things like diabetes and hypertension are only going to be things that everyone has to deal with as we get older and our population gets older. Doing the medical management is paramount. Taking care of yourself, exercising, and trying to live a well-balanced and healthy lifestyle is what you can do. If you identify that you have any of these symptoms, it's important that you seek out the care of a vascular surgeon so that we can effectively monitor you, so that ultimately, if you do present, you're presenting earlier. And that provides us with an opportunity to take care of you sooner. Your disease won't be as advanced, and ultimately your outcomes could be expected to be the best that they could ever be. It takes a village to care for these patients. And I think it's very, very important. And one thing that sets us apart at Presbyterian Dallas and, at the university at UT Southwestern is we've implemented these multidisciplinary care programs where patients are evaluated with peripheral arterial disease by multiple specialists. Everyone is involved. At the university in particular, and what I'm trying to implement at Texas Health Dallas, is the creation of these clinics where a patient can come in on one day and be seen by multiple specialists at one appointment. Not only does that make it easier for patients, but it allows for the physicians to all be on the same page so that we can tailor your care in the most expedited fashion, thereby allowing us to get the best results for you. But thank you so much for the opportunity to speak with you guys about a topic that's very close to my heart today.
We've been listening to Dr. Michael Siah. He's a vascular surgeon at Texas Health Dallas. Thank you so much for some great information. Steve?
Thanks, Thomas. And as we look to next week and we begin October, it's Breast Cancer Awareness Month. And we're going to have segments where women explain their journey with breast cancer. So please join us as we open breast cancer awareness segments next week on the human side of healthcare.